our first speaker is Dr. Sharma. So he will be talking about the etiology, clinical diagnosis, and workup and medical treatment of corneal perforation. Over to Dr. Sharma.
Good morning, everybody. We have this course on practical approach to manage corneal perforations, a case-based and video-assisted course. We have eminent faculty for this course, and our faculty is going to cover the various areas, including management of corneal perforations with CTA, with fibrin glue, management of PUK, management of corneal perforations in chemical injuries, therapeutic penetrating keratoplasty, and conjunctival pedicle graft. So first I will be talking about etiology, diagnosis, workup, and medical management of corneal perforation. Well, corneal perforation, if we look at from clinical point of view, there are various terminologies used: corneal perforations, corneal fistula, desmatoseals, filtering desmatoseals, impending perforations, pre-perforated corneal ulcers. Well, these terms may appear different, but the basic pathology remains same, and from management point of view, it doesn't make much difference. If we look at the etiology, it can be broadly divided into post-infective keratitis, which is probably the most common cause, rheumatoid arthritis, dry eye, chemical injuries, neurotrophic, and there may be some rare causes of corneal perforations. Just at the etiopathogenesis of corneal perforation, we all are aware that inflammatory cells in corneal diseases, bacteria, and stromal keratocytes, these release collagenolytic enzymes, and in any ulcerative pathology, these enzymes, they cause keratolysis, corneal thinning, and finally corneal perforation. Corneal perforation is often missed and is an underdiagnosed condition. When we have a large corneal perforation, where the iris is presenting, AC is absent, the diagnosis of corneal perforation is evident. But there may be subtle signs of corneal perforation, including filtering desmatocele. There may be radial folds in the descemet's membrane, which indicate early leakage. Corneal hemorrhage is again an indication that there has been some pressure changes and hemorrhage, shallow AC. So for all these, we need to do a test, which is a confirmatory test, and we call it Siddle's test. You put fluorescein, concentrated fluorescein, so under the cobalt blue filter, it will appear blue, and if there is a leakage, there will be green lake. In case you have put less fluorescein, then it may appear brown only, and there may be clearing of this area. If your test is not coming positive, put a mild pressure, and you may get positive. If the patient is having dry eye, you have to put more of the solutions. Infective keratitis workup is necessary. Depending upon the etiology, autoimmune disease workup is also very necessary. Once the corneal perforation occurs in a corneal disorder, medical treatment alone is not indicated. You need some augmentation in the form of tissue adhesives, therapeutic penetrating keratoplasty, therapeutic deep anterior lamellar keratoplasty, or conjunctival grafts. These are some of the things which should not be done. You can see a lady having corneal ulcer, his eye is totally closed, and treating physician has chose not to disturb it. But it should not be, you clean it, look at what is the etiology, and then do it. Conjunctival flaps, again, is not a proper treatment for infective corneal ulcers with perforations. Tarsorrhaphy alone is, again, not indicated. If we don't treat corneal perforations, we are bound to have sequelae in the form of retinal detachment, choroidal detachment, extrusion of the lens or vitreous, endophthalmitis, and phthisis bulbi. Well, timely management of corneal perforation is necessary. Otherwise, Titanic is going to sink and is going to cause corneal blindness, which itself is a disaster. So I would like to emphasize that high index of suspicion, clinical diagnosis and serial tests should be done to confirm the perforation, and emergency management should be done to treat these patients.